Okay, the last talk in this section is about the bone, something we have really not talked about clinically very much. And I think in meetings like this, just like any other meeting, we spend a lot of time on the cartilage, and that's pretty appropriate because cartilage is confusing. We have a lot of choices to make when we resurface a joint. But we've known something for a long time now. We've known that the bone below the cartilage is one of the main pain generators within the knee. And for most part, we've kind of ignored it. At least our profession has. And so then this year we're starting to realize, geez, if we're really going to get a lot of benefit out of our resurfacing, we've got to pay attention to the bone. And the literature is very clear, and high-level studies showing bone marrow lesions, the strongest predictor of the presence of pain associated with knee osteoarthritis. It certainly correlates with OA and disease progression. 9 times more likely to progress to total knee replacement. These are significant findings with bone marrow lesions. Well, to understand it more, we have to break it up into the 2 main types of bone marrow lesions. First is the, quote, bone bruise. This is the type 1 acute injury where actually if you look at this under the microscope, there's actually cracks within the trabecular bone. You also see edema surrounding that area of bone, and you see areas, again, of fissuring and cracking of the cancellous bone. So this is the key component about type 1 is marrow edema and local hemorrhage. And case in point, again, is the bone marrow pattern of an ACL tear. Type 2 is quite different because this is typically present in patients where they don't have this history of trauma. And when you look at it in the microscope, there's almost no edema at all. And what there is instead is extensive fibrosis and even areas of osteonecrosis. And that's important to differentiate because this isn't inflammation and this isn't going away with time. And when we start looking at the studies, and the studies that look at patients and taking them out and differentiating the patients that have bone marrow lesions, those patients don't do as well as the patients without the bone marrow problems. So let's start talking about this in a case-based format here. This is a 34-year-old patient who's now had knee pain for 5 years, recurrent effusions, mechanical symptoms. There is this history of the use of steroids for asthma when the patient was younger. Bad news is physical therapy for greater than 3 months, NSAIDs did not help this patient at all. Going back, if you look at the arrows, there's significant involvement of the bone below the area of the cartilage defect. Well, we can maybe categorize this in our mind in 3 potential ways that we can deal with bone marrow problems. One is the biologic way. Maybe we can reformat the healing to really heal up these lesions. 2, apply more structure, support for that abnormal bone. And 3, like the case we talked about earlier, get rid of the abnormal bone. And that's where the osteochondral allograft transplants can be performed. Let's go down the biologic pathway for this particular patient. So here at the beginning part, fluoro-guided placement of K-wires are done until you get to that area just below the cartilage surface. Then typically the K-wire is left in place and the reamer is placed over it to increase blood flow to the area and increase the area that's available for bone marrow concentrate aspirate if you would like to do that. Typical reaming diameters around 4 millimeters for these particular type of lesions. Next is perform the bone marrow aspiration, just as we've talked about in a couple talks ago, and you're welcome always to use the centrifuge to increase the numbers. Then injection of the bone marrow concentrate, always with thrombin in these particular cases. Whether it's bone marrow aspirate or whether you concentrate it, a combination injection to allow the aspirate to gel immediately when it goes in. And then it can be injected right down through the drill bit if you're doing this minimally invasively. This type of treatment is largely anecdotal at this point. A lot of studies are being performed. I just wanted to show you the power of this type of biology. Here is preoperative and postoperative scans, and you see in the preoperative scans a significant involvement of the bone below the cartilage. And this is only at 3 months, but you see how it allows the remodeling of the bone right below this area. Yes, this is resurfaced also with de novo, but again, with changing the environment locally to the bone, this may really significantly improve our results in the future. Let's take another type of patient. This is different. This is a 55-year-old, knee pain for 2 years. Last 6 months, however, this knee pain is rocketed from a 2 to a 3 out of 10 to an 8 out of 10, and now unable to exercise or use the stairs. Looking at this MRI, we see two things: the obvious tear, the degenerative tear of the meniscus, a little bit of arthritis, and a large amount of lateral tibial plateau edema or fibrosis, depending on which type of injury this is. Again, failure of physical therapy and NSAIDs, which most people would do in osteoarthritic patient population. So now what do we do when this patient's not getting better? Again, we have the same choices what to do, but removal of this bone in the tibial plateau is much more problematic. Let's go down the structural pathway for this particular patient. First is the arthroscopy to take away other pain generators. I'm going to make an argument later that arthroscopy should actually be done last, but for the sake of discussion, arthroscopy first, take away the meniscus tears and any other interarticular pain generators. Second, place the needle under fluoroscopic guidance. And notice the needle is very close to the subchondral bone versus placing it much further away from the joint surface. And next, inject the bioactive cement. Well, what is this biologic cement? Well, it's chemically similar to hydroxyapatite, but it's very different than bone cement. Because this is endothermic versus exothermic upon injection, it has compressive strength that is different than regular bone cement. It's near cancellous bone. It stays in paste form for at least 15 minutes, and it's formulated to flow. So therefore, when you inject it, it interdigitates among the trabecular bone spaces. Here's a picture of fluoroscopy just to show what it is like to inject this. And again, you can see the injection ports, which you can clearly see at the edge of the needle. And so what's injected, you can see the blanch here of the cement as it's going in, and then you could apply the amount of cement that you think is right. Then you can withdraw the needle, and you can again apply it over the area of the edema or the fibrosis. When you get to the end, when you think that you have injected enough, you need to keep the needle in for around 7 minutes. Otherwise, this cement does flow. So if you take the needle out, it will flow out of your bone portal. And there's the finished product. Here's an MRI of one of my colleagues, Zach Vaughn. He does a lot of this, has been really re-imaging these patients. Here's a patient 1 year post-op with significant, moderate to significant arthritis, but bone marrow lesions, and 1 year later their pain was almost completely gone, markedly improved, and so was the bone marrow fibrosis, at least per MRI. The biggest study now is Steve Cohen's data, which is 66 patients with a 2-year follow-up. These all had much more significant osteoarthritis, and this is what this indication has been used for more than any others. And out of the 66, 57 were worse, and you see the decrease in the VAS scores, the visual analog pain scores, pretty significant. But there's some pearls to doing this, which I have learned the hard way of experimenting with this technique. Number one, consider, as I was talking about before, and doing the subchondroplasty first. Because these really are subchondral fractures that we hear our radiologists talk about all the time. And you can actually prove that by injecting the cement below in the trabecula, and actually comes out of the articular surface, and the cement then collects in the joint. And there has been some initial data to suggest that pain increases for the first week after this type of procedure, but I honestly think it's because this bone in certain patient does escape into the joint and needs to be removed. The next is injection slowly, because this is a closed space within the bone marrow which does not like pressure. And that's for a lot of studies around the hip have proven that. So when you're injecting the cement, do so slowly, and this has also markedly decreased the amount of postoperative pain that these patients have experienced. Consider placing the needle near the subchondral bone rather than away, because we don't know how much the cement truly interdigitates, and we want to support that cartilage below the articular surface. Sorry, the bone below the articular surface. So in 2016, we do have choices. We can take that bone out completely, we can biologically restructure it, or we can structurally fortify it with bioactive cement. But we probably in the future should not forget about treating the subchondral bone. Thank you very much.